So I ended up seeing this reproductive immunologist who works on systemic inflammation. And it's a very new field that it's really kind of almost like longevity, where they're like, oh, it's iffy. We don't know the data behind it, but there must be something there because it's working. So I had my last child 9 years after I had my last baby is 3 years old. And there's a big age gap because it took me so long to finally be able to get pregnant and hold on to that pregnancy. And it was by treating my underlying inflammation.
We're here today and doing this live, so we're just going to jump into it because the point of being here today is to educate ourselves. And when we started the Peony Project, we were really intentional. And Jennifer Lewis, who was really the mind and brains behind starting the Peony Project, said to me and Christina, I want it to be about education. I want this not to be a place where we come and we get dressed up and go to dinner and then we leave and have no idea why we came. I want this to be a place where women, educated, smart, interesting, talented women come together and leave knowing why they were there. And then talk about it with their friends and their families and their daughters and their nieces and their moms and their grandmothers and say, listen to what I talked about today and what I learned today. And this is what you're going to understand better now too. So that's what we're doing here today. And these two women with me, I'm going to briefly introduce. Annbeth Eschbach is a CEO and co-founder of Reset One. She is a longevity trailblazer and the former CEO of Kindbody. Annbeth is reshaping preventive care through science-backed health programs. And she is really an expert on this topic of longevity, which is something I'm pretty sure all of us have been talking about and thinking about and doing, whether it's taking a GLP-1, whether it's going to get certain kinds of special massages that make your muscles feel better, or it's all the things, whether it's putting a wearable on and checking what your heart rate's doing. But there's all sorts of things that we can be doing to live better, healthier lives, not just living longer, but living better. And so we're going to dive into that. And Dr. Roohi Jeelani, who flew in from Chicago to be here today, is a reproductive endocrinologist and also medical advisor on Reset One. And she's a double board certified fertility expert and a leading voice in oncofertility, which we will explain later and get into, and hormone health. And I want to start with you. And I want to start, if you don't mind, telling us a little bit about kind of your story and why this is your area of expertise, because it's really interesting and really fascinating, and I think really important to the overall sort of theme of today.
Yeah. My name is Roohi. Thank you for the very kind introduction. And I'm a fertility doctor in short. And I found my passion very early on in life. I was telling Amy when we first met, she asked, why did I want to be a fertility doctor and when did it come? Most people kind of realize what they want to do and what they want to be as they're navigating medical school or even pre-med. But around the age of 11, my parents went through a very traumatic divorce, and we moved from a very small town in Newton, Kansas, where I grew up, to a really big city in Chicago, where my mom was from. So when we moved there, my mom, who was not supported by her family for going through this divorce, was constantly worried about the impact it would have on her 3 kids, because she was constantly told that you're going to ruin your kids' lives. They're not ever going to be who they should be because you don't have a man to support you. And if you guys know my mom, she's a trailblazer, and she definitely will do what she puts her mind and heart to. And she's like, no, I'm going to make it happen and I'm going to be successful. And so are my kids. I put a little wrench in it because I was not hitting puberty. So here I was 11, then 12, then 13. And every year we would go to my pediatric visit and she'd be like, something's wrong with my daughter. She's not hitting puberty. And then they didn't make it any better. Like, she looks kind of skinny. I think she's anorexic. So every year she would feed me hamburgers, croissant sandwiches, Dr. Pepper every morning. We eat a Snickers bar for lunch. And she went back and she's like, it's not working. Something's really wrong with her. And she's 14 now. So she told her older brother, who was a doctor, and he said, you know what? Me and my wife ended up going to a fertility doctor, and I think they do hormones. Why don't you take her to this doctor? So we took her to this doctor who's her initials are the same as my initials, RJ. Well, this is my married name, so I'm a RJ now. And we walk in this room, and I'm sitting here as this 14-year-old, and I come from a very conservative Indian family. We never talk about any of this stuff. And I can hear my mom talking to my doctor, but she never talks to me directly. And the doctor never talks to me directly. They're both talking about me in the room. So I don't really know why I'm at this fertility doctor. So I'm sitting in this waiting room and I'm looking around, and there's so much emotion. And I literally remember sitting next to a lady who's crying and somebody who's smiling, somebody who's jumping up with joy. And I'm panicking because I don't know why I'm there. So we walk in, and she very politely, the doctor tells my mom to step out. I'm still appalled because everywhere I look around in the room, and if you guys remember waiting rooms and doctors' offices in the 90s, there's lots of pictures, right? Pictures that are mind boggling, that you don't really look about a baby coming through the birth canal and breasts and things that we don't talk about. I remember calling them private parts. So she tells my mom to step out, and I'm so fearful of what's going to happen to me. So I asked this doctor, "What do you do? Who are you?" And very thoughtfully and very kindly, and in her really soft voice, she said, "I make babies." And I was like, "Oh my God." I was like, "I thought God made babies. I want to be you. I want to make babies." So that whole appointment, I was so fascinated by what she did and how can somebody make a baby in a lab that I didn't even care what my diagnosis was. And I remember walking away, she said, "You're going to need my help one day." And I was like, "I don't care. I just want to be you." So every year I would ask her, "How do I be you? What do I have to do?" And this field was so young that it actually wasn't an official fellowship. And I remember as I progressed through life, one day she told me, "Hey, this is a fellowship." And then she's like, "This is really competitive." And I was like, "I don't care. I'm going to be you. I'm going to come back. I'm going to work in this building." And I was lucky enough to eventually come back and work in that building with her.
That's pretty amazing. And then she was your mentor?
She was actually my mentor. I lost touch with her when I went off to college, and she kept coming back in my life in really odd times. So I remember leaving to college, and then I started modeling in the middle. And so I kind of swerved off road, knowing I'm still going to be a fertility doctor. And my counselor said, "Well, models don't become doctors." So I was like, well, now I have to do something else to build my resume. So I started cold calling fertility practices to do research. And then I found it's called Reproductive Genetics Institute. So I started doing genetics research there. And she was a doctor that would use the lab there, surprisingly. So she re-entered my life. And then I lost touch again. And then when I was looking to leave my oncofertility position with the NIH, I started looking at practices, and she was having dinner at the table right next to one of my friends, very coincidentally. And my friend, Dr. Jabamoni, helped my friend have her baby. So she was introducing her children to her. And she said, "My friend is looking for a job." And Dr. Jabamoni goes, "Oh, who's your friend?" And she goes, "Oh, her name is Roohi." And Dr. Jabamoni's like, "Oh my God, my little Roohi became a fertility doctor." And she hammer called me and said, "I told you I would be retired, but I'm actually not. And I'm about to retire, but I would love for you to meet the doctor I'm selling my practice to." And that's how I met Annbeth.
That's amazing. So will you tell us a little bit about the diagnosis that you had and how that relates to fertility? Because a lot of women either hear or know women with the diagnosis and what that means.
Yeah. So I have something called polycystic ovarian syndrome. Most people know it as PCOS, and I don't fit the typical phenotype because when people think of PCOS, they think of obesity, excessive hair growth, acne, all the high testosterone driven symptoms. But PCOS presents very differently in everyone. And it's actually the most common diagnosis we see as fertility specialists. The prevalence is anywhere from 20 to 25%. And most people aren't diagnosed until they actually start trying to conceive. And how it ties into longevity is it's actually a metabolic syndrome. So while my mom was giving me all these hamburgers and Cokes and Snickers, she was making it actually worse because it was making my insulin spike and my blood sugar go up, and thereby causing more testosterone production and preventing me from ovulating. So a lot of infertility or fertility can be really preventable, or we can diagnose it earlier by just understanding and learning about our bodies.
So most women don't understand they have PCOS until their 20s, 30s, but they could know earlier.
100%.
And so how would they know earlier? Women with high metabolism or women with...
Usually the most common symptom is irregular cycles. And not that you can't solve. We typically go to our doctor. We say, my cycles have been off by a couple of days, or I've been noticing acne or hair growth. And then we get a birth control pill, which is okay because that's technically the treatment for it. But if you understand your diagnosis that, hey, you have PCOS and I'm treating you with birth control, so much better, because then when you're getting ready to conceive, you know when to reach out to the appropriate doctors for help instead of being completely surprised. Like my cycles, I get that all the time. My patients are like, well, they were irregular, but I was young, and then they fixed by birth control.
And then how much more difficult is it to get pregnant if you have PCOS?
So if it depends on the type of PCOS. So if you're not ovulating, you definitely need fertility help. If you're ovulating, we still know there's an underlying egg quality problem. So we say independent of age, try for 6 months. And if you're not conceiving, then come see us. And then even after you're done having kids, if you've had PCOS when you're younger, you're at higher risk of uterine cancer, you're at higher risk of diabetes, you're at higher risk of high blood pressure. So it's important to know that it's not just a fertility disorder, it's a lifelong disorder.
Okay. And then Annbeth, how does the longevity piece fit into this?
I think that women, for the most part, I think I've already told you this, we look at women as truly the biggest opportunity that's out there, besides the fact that, more than 50% of the population, but women have been overlooked, misdiagnosed, kind of forgotten. And we deserve to live better and to be ahead of so I'm old, but all that I ever knew about was I don't want to get pregnant, having a child, or I now desperately want to get pregnant. And then the other milestone is menopause. Today, all these wonderful young women have access to really proactive, preventive, precise care and can get ahead of all of these stages, including the PCOS, right? The preconception work that you can do. And so we have the tools and the data and the science and the technology and the wearables that we're able to figure out what we should be doing at every single stage of life so that we can live younger, better, stronger. That's what we say we're doing. We're helping people live younger, stronger, sharper, better. And so just one example of that is hormones. And I was yanked off of HRT when I was young, after I'd had my son, because of the cancer scare, breast cancer scare. So I just powered through life like probably half the people in this room. And then 6-7 months ago, I was put on bioidentical hormones through my longevity doctor. And my life has completely changed. My cognition has changed. My energy has changed. What else has changed? Everything. I just feel amazing. And it's all being tracked and it's all being supervised medically. It's completely different than anything that you would take or you would take, because every one of us is different. But hormones are just one thing. We have multiple tools, lifestyle, peptides, other things, so that we can get out in front of these things. So anyway, I commend all of you for being part of this foundation and the great work that you're doing, because so many people's lives can be better and we can prevent so much of the pain and the decline that goes on and the disease.
Yeah. Can we talk about peptides for a minute? Is anyone else really interested in peptides? So I know what they are, but then I don't know what they are. And it's all anyone I know talks about. At all ages. And truly, my husband won't stop talking about peptides.
Is he on it?
He is almost on them. So he has like knee issues and whatever, and wants to talk about peptides. So will you talk about peptides? Because even like GLP-1 is a peptide.
GLP, good for you.
Right? Yeah.
So I'm going to let Roohi do the doctor speak. I'm not a doctor.
I want on both sides.
But I will tell you from a consumer or let's say a patient point of view, peptides do what your body, most of them, what your body already does. But as we age, those things slow down. And so I'm going to give you one small example. I have been uber active my entire life. I've had my hip replaced, knee done. Oh my God, a million things done to fix all of my breaks and, things. And I've really lived an active life. But in the last 7 years, I've been living with chronic back pain, chronic knee pain, chronic hip. Oh my gosh. And I'm just complaining and whining all the time. And anyway, I went on a peptide called BPC 157, which is actually a different name because of whatever. I have zero inflammation anymore. My back doesn't go out every 2 days. I am able to hike. I'm able to do heavy weightlifting. I'm able to do everything that I ever used to do except run in marathons. I've had to give that up. But the point is that I don't have inflammation. That's a peptide, and I love it. I could talk about a million others, but every one of us has a different set of goals. So there are different peptides that could work. Don't buy them on the internet. You must see a physician.
Well, that we've all learned over the last years. We don't do anything without our doctor. But will you explain, Roohi, about sort of the scientific side of peptides and I guess a handful of the different ones? Let's talk a little bit about GLP-1s because I'm sure we're all hearing about them, talking about them. Some of us are on them, benefits of them, and then also dig into inflammation as well, because that's such a huge, I don't want to even use the word buzzword, but inflammation is enormous, pardon the pun, but also in terms of cancer prevention.
Yep. So it's the root cause. Inflammation is the root cause of a lot of diseases, including cancer, including infertility, and including heart disease and diabetes. And that's the root cause. So I'm going to tie it back to why I'm interested in how I work with Annbeth. After being diagnosed with PCOS, I knew I would need help eventually when I was ready. I do have 3 kids, but through IVF. And I was always told, with PCOS, you have a lot of eggs, but it's easy to get pregnant and stay pregnant. But in my case, I would get these eggs and I would implant and I would miscarry. I wouldn't even make it past 5 weeks and then I would miscarry. Finally, the doctor's like, we don't know what's wrong with you. Your eggs are really crappy. Go get a donor. And I couldn't find a donor. I'm Indian. I was like, there's no way I'm going to find a donor here. Then I finally made embryos and still wouldn't work. They're like, now you need a surrogate. I'm like, well, there's clearly something wrong because first you said I couldn't get eggs. Then I made eggs from embryos. And then now I have embryos. Now you're saying I can't carry because it's my body. And not that I'm against any of this. I do this for a living, but help me understand my body. Like, what can I do better? Because it's a signal that if I can't hold a child or if my body's attacking it, that there's underlying systemic inflammation. So I ended up seeing this reproductive immunologist who works on systemic inflammation. And it's a very new field that it's really kind of almost like longevity, where they're like, there's, it's iffy. We don't know the data behind it, but there must be something there because it's working. So I had my last child 9 years after I had my last baby is 3 years old. And there's a big age gap because it took me so long to finally be able to get pregnant and hold on to that pregnancy. And it was by treating my underlying inflammation. So after I delivered her, it became
pause.
Yeah.
How did you do that?
I ended up treating my inflammation. So while trying to get pregnant with her, I ended up seeing an immunologist who worked more in this naturopathic systemic inflammation. So I was on an oral pill called low dose naltrexone, and LDN, which is also used in longevity medicine. And in high doses, it's used as an opioid agonist. So it's used in overdose. So when people hear about it, they panic. But if you look at it in naturopathic or immune medicine, at very micro doses, it's used to treat Hashimoto's or any autoimmune condition because it works on the receptor to decrease inflammation. So I was on it for 6 weeks to control my systemic inflammation, to decrease my C-reactive protein, to kind of work on my inflammatory markers. And then finally, I started treatment in August, and I did my embryo transfer in November. And I continued to stay on these immune modulators. And then I delivered her early, still ended up getting sick, but I finally had her at 35 weeks. But it was through the utilization of metformin, which is also used in longevity medicine, low dose naltrexone. A lot of these peptides are not FDA approved, so we have to be mindful. A lot of it's because they're naturally occurring substances, and with all the politics and everything going on in the FDA world, it's really hard to pass something. So that's one of the big reasons I left. I was a Warher Scholar for the NIH, a Women's Reproductive Health Research Grant. And my passion was oncofertility because we carry the ATM gene mutation. And out of my five aunts, my mom's the only sister who hasn't had breast or ovarian cancer.
Will you talk about that genetic mutation for just a minute?
Yeah. So ATM gene is a mutation not as common as BRCA, but it's linked with breast and ovarian cancer and other types of cancer like pancreatic cancer. It's one of the newer genes that's been identified in the mid 2000s. So actually they kept telling my family members that there's nothing wrong with you guys. This is not genetic. This is a coincidence, which is crazy, right? Like 4 out of 5 people to have this and not be genetic. So finally the same aunt who fought stage 4 ovarian cancer ended up getting breast cancer in the early 2020s. And I was like, please just get tested. You have a daughter. Just, it's very rare to get both, and to get cured by both is even, rare. Yeah. Typically, cancers that are genetically predisposed are very sensitive to treatment. So they're better than getting a cancer that's not genetically predisposed. So the fact that she was able to fight both stage 4 ovarian and breast cancer is no short of a miracle. So I'm like, there has to be a gene that's linked to you. So finally, we were diagnosed with the ATM gene mutation, actually, while I was going through IVF with my daughter. And we found out in October, and I was going to do my transfer in November. So there's ways to prevent. If you know somebody who has a genetic mutation, you could do IVF with genetic testing to prevent passing it on to your children. I did not do that because it was my last embryo. And I was like, at this point, I can't make more embryos. I'm in my 40s. So, we'll have to counsel her better and educate her. So I'm glad there's foundations like these to get information. But it's a cancer gene. Essentially, it's an autosomal dominant. So it's a 50% chance of passing it on to your children, including your male children.
So fascinating to me. How do you take it out?
You do what's called IVF with PGTM. That's pre-implantation genetic testing for monosomic or single gene disorders. It's a single gene that's mutated. So you would trace your family. So if I ever wanted to do that, I don't have it, but if I had it, I would have to trace me, my mom, and then they create a magnet or a probe. And once you do IVF, they touch the probe to see if it matches. And if that gene matches, that means your embryo is affected. That embryo then carries the genetic mutation, so you don't transfer it. I have patients that know and still transfer. It's autonomy, but at least they're well counseled that, hey, this child they're going to have is going to have this genetic mutation.
One of the fascinating things about fertility today is back when I was going through my fertility challenge, we didn't talk about genetic testing. And today at Kindbody, more than 70% of patients going through IVF go through genetic testing as well. It's a whole nother stage. Yeah. So it's increasing your chances of success. It's increasing outcomes.
Yeah. So since we've touched on that, will you talk a little bit more about oncofertility?
Yeah.
And what that means and what the indications are and who you see that are going through and dealing with oncofertility?
Yeah. The goal of oncofertility is to capture somebody at the time of diagnosis of their cancer. And there's a very short window that you can capture them, because usually what happens is they're clinically seen by their OB-GYN or their primary care. And then immediately, as soon as they're diagnosed through a biopsy with radiology, they get shoveled to a hematologist oncologist. There's usually a care coordinator that helps navigate their chemo, their surgical, and their radiation oncology. And then in that 2-week window, what I'm trying to do and what I've tried to do is create a program where, in addition to seeing breast oncologist or radiation oncologist, is see a fertility doctor. Because while they're coordinating their care, in the 2 weeks, and it only takes 2 weeks to fertilize or create eggs and embryos to freeze for your future. Because after you get chemo or radiation, remember, as females, we're born with all the eggs we'll ever have at birth. So at birth, we have nearly 2 to 3 million. Soon as we hit puberty, that number goes down to about 200,000. Our body just gets rid of all the eggs that are non-functional. And then every month we recruit 90 to 100 eggs. We ovulate one. and then we lose that 90 to 100. So by the time we hit menopause, an average age of menopause is 52, we're left to about 1,000 eggs. And over time, what happens is that the spindles, because we're created as all of us, that are required to break into half of us to join half the sperm, start to get tangled or tired. What chemo does is it accelerates ovarian aging. So although some people may have resumption of menses, their egg quality and quantity are significantly declined to where conception becomes almost impossible. So what we're trying to do is freeze their eggs and embryos in that little window where they're trying to coordinate their care, get their port placed so that I can freeze them. Most states, and I'm part of a lot of legislation that fights for this because a lot of states are not covering oncofertility. Illinois in 2017 became the third state to mandate oncofertility coverage, not only for the female, but for the male. Just like females, males have the same thing with their sperm. However, males are lucky in that in some cases they can regenerate sperm, their stem cells. As females, you can't regenerate your eggs. Once they're gone, they're gone. Or once they're damaged, they're damaged.
And what is this sort of, I mean, this is almost a dumb question, but the mindset of a woman who's been diagnosed with cancer has 2 weeks before they start their treatment. And in those 2 weeks, there's like a tsunami has hit them, right? And they're going through so much. How do you navigate that with them? And so it's not something else on their list, but something to help them feel about their future.
Yeah.
And what do you see as their feedback?
It's all about counseling and patient education. I felt like when I was going through my own journey, one of the biggest things I lacked was, it sounds really crazy because I'm a doctor. You would think like, God, you do this for a living. How do you not know? But when you're hit with this really scary diagnosis and news, you're just besides yourself. And just like cancer, infertility robs something from you. So I always tell my patients, like, I know you've been hit with a very heavy diagnosis, but this is something you're going to start thinking about after the fact because there's going to be life after cancer. And what does that look like for you? Right. So my job is to protect you and to take the thinking out of it. And the biggest points that they won't want to do it is the time it's going to take to help them get to treating their cancer. So I always counsel them it's 10 to 14 days. I'm not going to take any extra time. Another big fear is, are you going to make my cancer worse because you're giving me hormones? So I educate them that this will not make your cancer worse. A third common fear I see is, well, you're taking eggs out when I have a cancer. When you put it back, are you going to give me cancer again? So I always counsel them that no, we can't seed the cancer. These are not active cells. And there's data to show that your cancer is not going to come back after I implant these embryos. And then the last thing is financial. Chemo is really expensive. Radiation is really expensive. So I counsel them with programs that we offer. There's programs that Big Pharma offers for cancer patients, including Walgreens, where they donate medication for fertility preservation.
So to totally switch gears, because that's a lot, can we talk about GLP-1s?
Yeah. Would you talk a little bit about one of the biggest myths with GLP-1 is a peptide and there's multiple strains. Would you talk about how the myth is that GLP-1s are exclusively for weight loss? And what we've now learned is they are a longevity peptide. And what you can do in a longevity physician supervised program is microdose. So you're not taking a big amount, you're taking a tiny amount, and the benefits are cognition, energy, sleep,
inflammation, decreasing systemic inflammation. So GLPs are a naturally occurring peptide and they decline as we age. So essentially, when you microdose a GLP independent of weight loss.
Can you explain what microdose means?
Yeah.
Because to a lot of people, including myself, and when you think about it, you think of like doing drugs.
Yeah. GLP is a peptide.
Right. And telling your kids microdosing is doing drugs. I don't care how little you're taking.
Yeah.
So just break that down for a sec.
GLPs are like the Ozempics of the world. So At higher doses, it serves to decrease appetite and for weight loss. However, if you take it at a smaller dose, so the standard dose is about 25 units and you titrate up. But if you take anywhere between 5 to 10 units on a weekly, it's not necessarily for weight loss, but it's more for inflammation. So it decreases systemic inflammation, which works with longevity. I did it for a little bit. So after I had my daughter, I remember going on this vacation and telling my husband, and I texted Annbeth, I was like, oh my God, I look awful. I've never had this. I don't have body dysmorphia. I'll start with that. But I was like, I have a central pad of fat and I've never had this. And my husband's like, oh, it's because you're in your 40s and you had your baby in your 40s. What did you expect? And I was like, no, I'm like, that is not what I expected. Yeah, not acceptable. And so that's how I started looking into, well, why is this happening? And as we get older, all of these naturally occurring peptides start to decline. And that's why you're at higher risk of metabolic syndrome and heart disease and diabetes. And if you notice, all women, Alzheimer's, cognitive function starts to decline. So that's when our estrogen starts to decline. That's when our metabolism starts to slow down. So that's when these peptides play a role to kind of help you live a healthier life. Not just, it's not just for physical appearance, but it's overall. I went back home and I checked my A1C and I was pre-diabetic. And I was like, oh my God, this makes sense because I feel like I'm pre-diabetic. I'm gaining weight like a diabetic would. And it's in those areas. And I need to treat that before it gets really bad and I start having a heart attack in my 40s.
I just want you to give a medical definition of systemic inflammation.
Yeah. So systemic inflammation is also not, if you go to a doctor and you say, I think I have inflammation, they're going to completely dismiss you because not a lot of people necessarily believe in it, right? But like Amy was saying earlier, you know your body better than anybody. Systemic inflammation typically is medically described by elevated serum markers like C-reactive protein. There's other inflammatory markers that you could test. I test natural killer cells in my fertility patients, which is also a marker of inflammation. You can test it through your white count, but you don't necessarily need to have those. For me, what was a good signal that I was having systemic inflammation was truly central obesity. I was like, this is not how my body looks. And I don't feel like myself. And when I went and checked, my hemoglobin A1C, which is a marker of diabetes, was extremely elevated for my weight, my height, and my age. So that to me is systemic inflammation. So anytime you have these spikes, even when you look at heart disease, when you look at a heart attack or a stroke, you need two hits, right? Like having high cholesterol alone doesn't predispose you to a heart attack. It's having high cholesterol, which then combined with inflammation causes plaque formation, then narrows your blood vessels to give you the heart attack. So if you eliminate any inflammatory factors, and the inflammatory factors are very different for everybody. For me, it's carbs and sugar. I can feel it and I know it because I'm predisposed with my PCOS to that. I can feel lethargy. I don't feel like myself. My blood markers are always thrown off when I eat bad. The next 3 months, I can truly tell through a medical diagnosis that that's what I lived bad in those 3 months.
So does everybody here know that in the last couple of years, we've been able to decouple or uncouple biological age from chronological age, which means that if you're 65, if you're you probably are 20 years younger than your chronological age. Your chronological age is, your birthday, how many years you've lived. Biologically, because today we now have, the science and the technology and the tools and there's an immense understanding that environment and lifestyle plays a big role in reducing your biological age. We have the ability to end this decade 10 years younger biologically than we are sitting here today. And about 30% of what drives your rate of aging is genetics, and 70% is lifestyle and environment. I always thought it was like 50-50. But, the fact that you guys are all here in Sun Valley surrounded by other Amazons, makes a big difference. But biological age is a marker that we study. And there's still a lot of stuff and a lot of science going around. Everybody's looking at it a little differently, but we have a whole algorithm. And so on our patients for the last 6 months, their biological age went down in 6 months by 6.5 years. And that's kind of a big deal because it's only 6 or 7 months.
Yeah. So like long-term side effects from IVF or long-term repercussions or things to know about when you're going down the IVF route.
Yeah. So in the short answer, there's no long-term repercussions to IVF. Just like our natural body produces fluctuation of hormones, like your estrogen goes up when you're about to ovulate, then it drops, your progesterone goes up. All IVF does is it's synthetic versions of your naturally occurring hormones to stimulate, instead of ovulating one egg, you recruit and grow all the eggs. So remember earlier I said your body activates 90 to 100 eggs, but it only makes enough food to grow one egg. So when you do IVF or egg freezing or embryo banking, I'm giving you more food to grow now all those eggs. That's called your antral follicle count. So typically we do an ultrasound and count the number of eggs, and then we give you a dose to try to grow that number of eggs. Soon as you stop the medication, it lasts in your body for 24 to 48 hours, and then it goes away. Your ovaries get pretty big because I grow them from a size of a tiny, tiny almond to the size of a watermelon. So you feel pretty sore for 4 to 6 weeks, but otherwise no long term. I would say that's the most common side effect, that bloat and discomfort. Tiny ones, the tiny seedless ones.
Not the ones that sitting outside at Atkinson's. Thank you both so much. Thank you for coming. Thank you for being here. And so one of the things that a takeaway from today is you might be way past the age of going through fertility. Most women here are needing fertility treatments, but many of you here have daughters, granddaughters, great-grandchildren who may one day go down that road. Women are having children way later in life. And so now you have some tools and some knowledge that you will guide them through that process. And your eyes will not need to have any sort of sympathy in them. And it'll be just like a norm. And you'll look at them and you'll help them and you'll hold their hand. And it won't be like in any different process than if you walked in and they called you and said, I'm pregnant. And they might say, I'm having fertility treatment. Come with me. And that is part of the beauty of why we do this. So we all know more, we're educated, we understand, and our empathy levels are risen up a little bit more. And I think that's a beautiful, beautiful gift that we can give to you and we can give ourselves, and then we can spread it along. So thank you so much for being here, all in the name of women that we love and that women we hold dear to our hearts.